Good now. I think it's actually been recording for 7.5 minutes. Okay.
Okay, so
all right.
Thank you so much, David, and I'll let you start.
Hi. Okay. So this is the follow-on from Rosie Adams, who spoke last week. Hello to everybody in the video world that we can't see right now, but maybe in the future you will be watching this. So I'm going to talk about acutely dizzy patients mostly, and also some vestibular function testing stuff if I've got time at the end. I work here as in audiology. I don't have a medical background, I have a scientific background, and I do vestibular diagnostics and a bit of rehab, and I do cochlear implants. And when I was training, I did an elective at Hopkins for quite a while with the people who developed HINTS, which is the acute dizziness protocol. That is more and more used in ED and should be widely used ideally. So I can talk a bit about that. Just to recap on what Rosie did last week, in terms of history, the people over there at Hopkins developed this kind of, it's an algorithm, but it's a really great approach to general history taking and to kind of fairly neat ways of classifying dizziness subtypes. So essentially, if you think about all dizziness, especially dizziness that has an acute onset, so maybe this is, I will put you soon. Yeah. Oh, you're doing that.
Yes, I'll do.
So this applies mostly to acute dizziness that you will come across. It applies less so in the outpatient setting where you've got someone who's been dizzy or off balance for months and months and months, but still essentially the same kind of things apply if you think back to how it began, right? So we split this into 4 subtypes, but let's start by splitting it into 2. So you've either got episodes of dizziness, so discrete episodes that start and end, or you've got a singular episode. So you've either got it happening multiple times or you've got it happening a single time. And then if you split those episodic and singular categories again, you either have episodes that are triggered reliably by something, or episodes that occur spontaneously and randomly with no warning. Similarly, if you have a singular event, it might be triggered by something, or it might have occurred completely spontaneously and randomly with no obvious cause. So if we look at episodic triggered stuff, this is BPPV mostly. On the whole, this will be BPPV. And these categories also happen to have, you want to think about the timing and the triggers. So each of these categories, they last for different periods of time, and they tend to be triggered by something or not, right? So for BPPV, this is dizziness or vertigo, which lasts for seconds to minutes, no more than that, really. The patients may overstate it. They may be like, oh, I've been dizzy for hours, absolutely hours. But when you ask them, was it spinning and how long did the spinning last for, then they're much more like, well, no, it only spanned for a minute or so, but then I felt terrible for hours afterwards. So BPPV is dizziness that lasts a very short time, and it's reliably triggered by movement. And particularly for BPPV, which I'm sure you all know, there are 6 movements in 3 pairs. It's either rolling to the left, rolling to the right in bed, lying back in bed, sitting up in bed, or vertical head movements, tipping your head back or tipping your head forward. So those are your BPPV triggers. Lateral head movements, quick horizontal head movements don't tend to trigger off BPPV unless it's horizontal BPPV, which is very rare. The other causes of episodic triggered dizziness would be postural hypertension, which is just usually a lightheadedness or maybe a momentary imbalance after standing up. And then central positional vertigo, which is super, super rare. And the thing about rare stuff is that you have to bear it in mind, but you also have to not be overwhelmed by it, because it's much more unlikely than the common God and peripheral benign stuff. And we won't go much into that today. Then episodic stuff that is spontaneous. So these are episodes that come out of the blue with no warning, usually, and no real triggers, and they last much longer. So I've put minutes to hours here, and that is certainly true of Meniere's disease. I think the Baroni criteria is something like 20 minutes to 12 hours. Vestibular migraine attacks can be quite similar and quite difficult to differentiate, but they tend to last longer. Although migraine can do anything it wants, it's a spectrum really. So you can have minute attacks of migraine, you can have chronic migraine, you can have classic hour-long or day-long migraines. Migraine's a massive spectrum, but those two are the main two kind of benign causes of episodes of vertigo and dizziness. And they will last longer than your BPPV episodes. And they tend to not be triggered by anything obvious, although some people will say it happens more when I'm stressed, or it happens when the weather changes, or it happens for women with hormonal fluctuations, migraine in particular. But generally, they come out of the blue. They might get a few seconds warning or a few minutes warning, but they are not triggered by movement. Then you've got your two categories of singular events. And triggered singular events are usually fairly obvious from the history because there's usually been some toxin or trauma. So, a temporal bone fracture or a massive dose of, a horrible drug or a carbon monoxide overdose or something. There's normally something fairly clear, and there's normally other stuff going on as well that will point you in that direction. The fourth category is mainly what I'm going to talk about now for the next 20 minutes or so, which is singular spontaneous an attack of vertigo that comes out of nowhere and is the main reason why people end up in the ED or on hospital wards with a primary dizziness is this category. And this tends to last for hours to days most acutely, so you might be spinning for hours to days constantly, and again it has no trigger. So that's what we're going to concentrate on. So this is often called the acute vestibular syndrome in the literature, and you are essentially looking at an inflammatory inner ear event like neuritis, most commonly neuritis, but occasionally labyrinthitis. That versus a posterior fossa stroke. And the thing about this is it's much less likely to be a posterior fossa stroke, but the morbidity associated with that is serious enough that it needs to be kept very much at the top of your mind when seeing acutely dizzy patients. So AVS, it's a collection of symptoms rather than a proper syndrome. It will have, vertigo is usually the primary, and the accompanying nystagmus is usually the primary symptom, but they will often have vomiting, and they will be very reluctant to move their heads, and they will often have an inability to walk. So severe imbalance, gait ataxia, severe disequilibrium. They just want to be on the floor or in bed. They have to hold on. They tell you that they had to hold on for the whole time that they were spinning. And that's gait ataxia to be distinct from truncal ataxia, which is much more of a central sign, which is much more associated with strokes, but we'll get onto that in a second. So yeah, the majority of it is peripheral, and I'm sure every ENT trainee, I'm sure knows this, but the difference is between neuritis and labyrinthitis is just the hearing loss. That's all it is. So neuritis is just the vestibular portion of the nerve, and those two, I wouldn't generally, if you don't know, I generally call them an inflammatory inner ear event. And then you've got about 20%, according to the literature, of acute vestibular syndrome that are caused by a stroke in the posterior fossa, either a TIA or more sort of serious CVA. And they often have no other focal neurological signs, which makes them kind of tricky to deal with. They will do, some of them, many of them, and there's also often there's quite an obvious cardiovascular risk factors going on, or previous history of strokes, possibly. But it's possible for young people to have vertebral artery dissection and have a sudden posterior fossa stroke and present only with vertigo. That is entirely possible. It's rare, but it's entirely possible. And posterior fossa strokes are largely ischemic, and they're approximately a fifth of all strokes. Going back to what we're probably more comfortable dealing with, yes, so these people will have sudden onset rotatory vertigo that comes out of nowhere, usually no previous history of dizziness, and they will have a positive head impulse, which we'll get on to in a second, because their VOR is down, their the labyrinth is not outputting to the brainstem, and they have no vestibular ocular reflex anymore, which we'll get onto in a second. They often have direction fixed nystagmus. Again, we'll get onto that in a second, and they don't have a skew deviation. Those things will make a bit more sense when I start talking about hints in a second. But as I'm sure you all know, we don't really want to get these patients hooked on any vestibular suppressants because they won't recover, they won't compensate. If they're really being sick, they can have antiemetics. But this nice article in the BMJ came out quite a few years ago now, and it was just trying to reinforce all the literature that, really they just need to go home and get over the neuritis and then get into vestibular rehab clinic as soon as possible. One of the reasons that I'm really into all of this stuff is that I see the patients that never got a good diagnosis, and I see the patients that went to hospital and were told they might be having a stroke and were admitted on a stroke pathway, and they spent weeks in hospital. Maybe they picked up a hospital-acquired infection, and all they ever had was vestibular neuritis, but they never got a good diagnosis at the time. And a lot of that, because there's a lot of anxiety associated with that, then we can turn into this form of chronic dizziness called persistent postural perceptual dizziness, which is essentially chronic subjective dizziness, and it's an absolute nightmare to rehab. And it can have a massive effect on people's quality of life and their ability to work. And so we see those patients later on down the line when they're persistently chronically dizzy. And we know from the literature that if patients are dealt with properly and diagnosed properly early on, there's much less risk of that happening. So one thing I should say before I carry on anymore, just for anyone who works at MFT or works certainly at the central site, is I should have said this at the start. Really, audiology don't have an on-call service. I would love to see more acutely dizzy patients, and the work that I've done in that area has been really satisfying and really good. But we just don't have the clinical capacity to do that. We have full outpatients clinic lists for most days, and when there is somebody who needs seeing on the ward, it's really difficult for us to get there. And if the request comes in on a Friday, it might not get looked at until the Monday. So we don't operate an on-call service, and it's changed over the years with depending on who the trainees are and who the ENT senior registrars are. Sometimes you guys have been willing to go down there and see the patients, and other times not so much, and they've been sent straight to us. But the party line from Emma Stapleton and Simon Lloyd and Simon Freeman is that any dizzy patient that has an ENT request put in needs to be seen by an ENT doctor first. And I think it's entirely possible to do that if you guys feel more comfortable with three things: taking a history, doing a Dix Hallpike, and doing a head impulse, because that will basically take care of 90.
Why we're here.
Yeah. That will take care of 90% of patients. Many of them have BPPV. I've seen people bed blocking for weeks who just had BPPV, and they never got seen by anyone who recognized that it was BPPV. So if you can do that and you can do a head impulse, you'll be able to discharge most patients fairly quickly. If it's more complex than that, or if you do, then there are three really good otologists here who are happy talking about dizziness and seeing dizzy patients, and then there are 4 audiologists here who know what they're doing as well, including me. So we are here to talk to you. Do you know what I mean? If you go and see someone, you're like, I'm quite sure, then I can even come down to the ward, or we can bring them over here and we can do some more testing. But ideally, if they can be seen by somebody fairly soon, what happens is the wards then just, if no one sees them, the wards just hold on to them and they just sit there for ages. And it's just not ideal at all.
Is there a way for us to call you guys?
Yeah, so
have the patient say, I'm actually not sure, or
yeah,
I think this is it, but
we would absolutely be happy to take those calls, or take an email, or just come down to Peter Mount and find somebody and have a chat about it anytime. It's really absolutely fine. And I enjoy that kind of stuff, but we just do not have the capacity to go and see them ourselves, which is annoying. But anyway, so I'll carry on. So yeah, even though you have to bear this stuff in mind, remember that it's far less common than an inflammatory inner ear event, but we need to make sure we don't miss anything. So posterior fossa strokes don't tend to produce focal neurological signs. They're often primary dizziness alone, but the patients often have identifiable cardiovascular risk factors. CT scans, which they'll all have had, by the time you get down there, they'll have had a CT head probably, and they're not very good for ischemic posterior fossa strokes, as I'm sure you know. And even DWI MRI does miss 20% in the first couple of days before the infarction starts to show. So that's why this HINTS protocol was developed to try and catch the strokes that are missed, because many of them don't come back with much bigger strokes. If they're discharged and told that you have vestibular neuritis and they've not had any testing to prove that, they're discharged and they often come back with much worse. So this is the guy that developed HINTS, and it's really well evidence-based now. It's been around for quite a long time, and it's been replicated again and again and again. And the ED have really woken up to this. Invariably, it depends on which ED consultants you talk to, but in general, the emergency community have woken up to it a bit. So this might be like teaching you all to suck eggs, but I'm just going to go through it. So HINTS is head impulse, nystagmus, test of skew, which we'll go through now. And the thing to remember, which I'm going to say multiple times, is you can only apply this when the patient has spontaneous nystagmus. So their eyes have to be moving. Now that we'll get onto it in a second, but if they're moving in the dark, that counts as well. But as long as there is nystagmus of some kind, then you can apply HINTS. The reasons for that will become clear in a second. So the head impulse is like the most important clinical bedside test in all of dizziness, with the possible exception of the Dix Hallpike. And it's really not that complicated, although you need a lot of practice to feel confident doing it. But when it's positive, it's fairly obviously positive. So test the vestibular ocular reflex, which is our old friend, the fastest reflex in the body, which is really just a 3-neuron arc out of the labyrinth, down the brainstem, back out to the eyes, which is why it's so fast. And it goes down the brainstem, so it does not go into the cerebellum. So if you have a big problem in your cerebellum, it is not going to affect your VOR, because that is a purely brainstem reflex, right? That will come in a second. So doing a head impulse, you're going to sit very close to the patient, look them in the eyes, and ask them to look at the bridge of your nose. You're going to hold their head nice and firmly, like I'm holding this guy's head here. And then you move it briskly to one side, to the side that you're testing. So you either right or left, and you do it a number of times. You want to do this so that you get the same exact thing happening every single time. Now, when it's normal, this is the normal subject across the top here. Okay, so he's looking at your eyes. He's still looking at your eyes. He's still looking at your eyes. So as you turn his head too quickly to the right, his eyes move quickly to the left to stay on your nose, because the vestibular ocular reflex is working perfectly. The right inner ear, the right lateral canal, has picked up that movement and has immediately moved the eyes to the left with exactly the same speed and degree of movement. And so his eyes kind of seem kind of weirdly still on you, like ghostly still looking at you. If this person has a right vestibular loss and you push his head quickly to the right lateral canal will not output a signal down to the brainstem, and the eyes will not know to move during the head impulse. So they will drift off your nose and he'll be looking away. And then, because he is in voluntary control of his eye movements and he knows he needs to look at your nose, you'll see then a very quick saccade back onto your nose. So that happens after a delay. It happens after about a 200 millisecond delay, which is the time it takes for the acknowledgement that he's no longer looking at your nose to come back from the visual cortex and move his eyes, and getting all the way back to the extraocular muscles. So that's why you can see it with the naked eye, because it's visually driven. Whereas this movement here is not visually driven. That's why the vestibular ocular reflex is so important, because it happens without visual input. The eyes just get moved by the ears. So here's a normal one. So what you can see is she's just constantly staring at the camera, and her eyes just seem like they're locked onto the camera, right? So there's no saccade there. The saccade is the fast eye movement that we're looking for, the catch-up saccade. So this is a normal impulse. Now this is a positive one. He's going to go to the right, and that's fine. Now he's going to go to the left, and bonk there. So you have to watch this a few times if you don't get it the first time. Goes to the right, it's fine. Now when he goes to the left, da-donk, there it is. You see that, Erica?
Yeah, I saw that.
Yeah. So it's off. It's it's there. Now it's tricky in older people because they don't always look directly at your nose. They're often flicking their eyes about, and they're often getting distracted, and people get anxious when there's somebody that close to them, so they move their eyes around a lot. And they're often, if this person is dizzy on a ward, you know, this is going to make them feel pretty dizzy. So that's why you need to do it multiple times and be sure you're seeing the same thing every single time. So if it's like every time you move the head to the left, the eyes do that like catch-up saccade every time, you know that's a positive head impulse. And there's no substitute for just doing this again and again and again on people. If you do it on, you know, 50 normal people, you'll definitely know what a normal one looks like. But you might not know what an abnormal one looks like. So you need to just go and do this on patients. So here's another positive one. Oh, this video is not working. If you're interested, there are absolutely tons of videos on the internet. Okay, now it looks like I'm losing a few slides here, which is annoying. I wonder if I can get on the shared drive.
It's in the loading book.
Yeah, it's just never mind. Hopefully I haven't lost. Oh no, I've lost a few more. It's annoying. Never mind. I'll have to talk around it. So this is just, so basically a normal head impulse alone is 91% sensitive and 99% specific for stroke in these patients. And what this picture would have been showing you is just that picture earlier about the location of the vestibular ocular reflex. If you have a cerebellar stroke, which most posterior fossa strokes are, it's not going to affect your VOR. It's not going to go anywhere near it. So your head impulse will be normal. So unlike a vestibular neuritis patient who will have a positive a positive head impulse, so they'll have the catch-up saccade, a posterior fossa stroke person will not. And that's true for the overwhelming majority of posterior fossa strokes because most of them are in the cerebellum. Very rarely they are in the brainstem, particularly ones that affect the lateral pons. And for those, you would still get a positive head impulse because that's interrupting the VOR. I hope that makes sense. Yeah. It's really, really rare, but it's rare. It's enough of an issue that they added in the other two elements of hints to try and bring up the sensitivity. So the other two elements of hints are an assessment of the nystagmus that the person has. So annoyingly, you cannot see this, but this is fairly easy to understand. So wherever the person looks, then the nystagmus will beat in the same direction. So the nystagmus has a slow phase and a fast phase, which means it goes drift, flick, drift, flick, drift, flick all the time. And it's constantly going drift, flick, drift, flick, drift, flick. And the flick is what we call the beat. So the side that it beats to will stay the same. And if they look in the direction of the beat, it will get bigger. And if they look away from it, it will get smaller. But wherever they look, the direction will stay the same. And with some exceptions, it doesn't really. When you diagnose people with vestibular neuritis, you don't necessarily need to know which ear it is, although the head impulse hopefully will tell you. But usually it beats towards the healthy ear. So it's basically, if it's flicking to the left, you know that the problem's probably on the right with vestibular type nystagmus. Now this is a cerebellar stroke, I think. So this guy, I don't know if you can see that, but as he looks to the left, he's got the beat is to the left. As he goes over to the right, the beat is to the right. Can you see how that changes direction?
We can't see David. We can't see this video.
Great, excellent. So, sorry, he said we can.
Are you sharing the slides only or your screen?
Did you say you can see them?
I can't.
Yeah. Oh, you can't. Oh, that's a shame. can see it here. Can you see? Oh, I know why, because it's not even sharing the. Can you see that?
Yeah, I can
Yes.
see it now.
Okay, great. Yeah, so this person looks over to the right, is looks over to the left, and he beats to the left, and now it goes all the way to the right, and the stronger, the faster, the stronger flick is to that side. It takes a while to get used to looking at this stuff, but once you see it, once you see it, you can't not see it. In posterior fossa stuff, it's usually pretty big. This is big nystagmus. It's not subtle. The other thing that's interesting here is as he moves his eyes over, his smooth pursuit is all choppy and broken up, which is massively a cerebellar sign. It's very likely that something like this will be recognized by the ED already, or by neurology, to be honest. So you may not see much of this. But if you do, and it changes direction, and so we say the fast phase is alternating, right? So there's a little mnemonic to remember the stroke findings in a second. I'll go through that. So the spontaneous nystagmus is what gives hence its sensitivity, and usually and often is visible to the naked eye. So if it's central and in the early stages of a peripheral event, like a vestibular neuritis, for the first couple of days, you'll be able to see it with the naked eye. And remember, if it's peripheral, it stays the same direction no matter where they look. And if it's central, it changes direction. As peripheral disorders compensate, as the time goes by, it becomes so that you can only see the nystagmus when we say fixation is removed, which basically means you turn the lights out. So if they don't have anything to look at, their cerebellum can no longer suppress the movement of the eyes, and it comes out, and you start to see this nystagmus that's generated by a problem with the vestibular organs. So when the nystagmus isn't visible with the naked eye, ideally, if you want to properly do hints, you need to remove the fixation. You need to basically turn out the lights. Now, I'm sure you're thinking, how are we going to see the patient's eyes if the lights are turned out? There are multiple ways to do it. We have a couple of pairs of these in the department. If you ever want to borrow them, you put them over the patient's eyes. They have like 50 diopter lenses, so the patient can't see anything out of them, but you can see their eyes very clearly, and they have little lights in them. So the patient can't see anything, and it will bring out a vestibular nystagmus. We can do this in our vestibular lab because we have big video goggles that have infrared lights, and you can see there you've got a nystagmus, and the patient can't see anything, and we're recording that there. The other cool trick you can do on a ward is you basically cover one of the eyes, and then you blind the other eye with your ophthalmoscope so they can't see anything at all, and you look at the back of the eye, and then you see the twitch. You see the optic nerve head twitching in it'll be in the opposite direction, but you don't need to know which direction it's twitching in. You just need to know that there was no nystagmus before, then you blind them essentially, and you bring out the nystagmus. That's so clearly vestibular. Does that make sense? So if you have a look at the back of their eye and cover the other one, and it starts twitching with nystagmus, then that's a fair sign that that's a vestibular nystagmus. It came out when fixation was removed. Okay, the final one, and this has been added in just to cover a few very, very rare causes, rare areas of the brainstem that will give you a positive head impulse. But so you won't see this very much. But this is just essentially, this is a vertical movement of the eye. A skew deviation is like it's a vertical movement of the eye when you cover and uncover. So what you might be able to see here is when he covers, his hand moves to the left, and then the right eye moves slightly up. As well as moving to the left, it moves slightly up. So if there's a vertical deviation of the eye, that's called a skew deviation. Now, this is something that's not really practiced much outside of ophthalmology and neurology, and I don't think anyone is necessarily like expecting ENT trainees to be happy doing skew deviation. And I would add that skew deviation has been added into hints to cover a few very, very rare things that bring the sensitivity down. But if you do this, if you cover cross cover and there's a big obvious movement of the eye vertically, then again that is a big stroke finding. So this is refixation on cover test. So that gives us a mnemonic. So the hints of the mnemonic: head impulse, nystagmus, and test of skew. That's what hint stands for. If you get any one of these, that points to a stroke. So if the impulse is normal, if the fast phase is alternating, or if there's a refixation on cover test, that points to a stroke. And so, you know, in an ideal world, everyone in the world would be great at doing this, and then we would scan less. But the reality is, we're still going to probably MRI scan these people just to be safe. But the quality of a really good diagnosis early on can't be understated, because it has a knock-on effect on everything else. The other thing I should say is that sudden unilateral hearing loss and autoimmune hearing loss and stuff is often, it comes along without vestibular problems. Very occasionally it does, but when these people have AVS, which is the vertigo and the nystagmus, and they also have a sudden unilateral hearing loss, there's a possibility that there is an inner ear stroke or a labyrinthine stroke of the vessels supplying the inner ear. And so if they have a complete hearing loss, they call that hint plus. So, you know, you would that would be another red flag for a stroke, like somebody with AVS who had a sudden unilateral hearing loss. It may very well maybe labyrinthitis, but labyrinthitis, it doesn't tend to completely wipe out the hearing. It tends to give you a somewhere between like a mild to severe hearing loss and mainly affecting the high frequencies, but a complete loss, that's really worrying. So that would again be a red flag. So just remember, hints can only be applied when there is spontaneous nystagmus. If you want help looking at the nystagmus, then I can come down to the ward. We're happy to come and look, or you can video it. You know, you can just take a video of it and show it to any of the otologists or any of those in the vestibular team in audiology. And if you fancy borrowing some frontal goggles or getting an ophthalmoscope out as well, that's really useful to do. But do not worry if you can't remember all this stuff. The main thing is the head impulse. The three most important things in acute dizziness are the history, the head impulse, and maybe the Dix Hallpack. So just to finish up, these goggles are called V-HIT goggles. They're called video head impulse goggles. Video head impulse test. We do tons of this here. We've got 3 sets of them. They are very, very useful, especially in the acute setting. And there has been, for the last 10 years, there's been a drive to try and get these into the acute setting. And there very well may be in the future a kind of automated algorithm that the paramedics maybe, or the ED doctors, or maybe in primary care, who knows, they can put, for dizzy patients, they can put these goggles on, and the computer runs you through some tests, and then it says, quick, take this person to the HASU because they're having a stroke. So that might be the future, but for now we use V-HIT quite a lot in audiology. The idea that they are very keen on in the States, because there's a lot of big distances involved in the States, is that if you can do these tests with video goggles, then you can send the information anywhere in the world and they can be looked at by an expert, and then, you know, and then you can have kind of tele-dizzy setup. But that, yeah, so this is the video head impulse test, and it also does the thing. It does all this stuff. It does the skew deviation. It does the nystagmus. You can do the whole hints battery on V-HIT, and then it can be checked by someone else. So that's possibly the future. For example, here is a person with no stroke who has a very positive head impulse to the right. That what you can see there is the catch-up saccade that you would see with the naked eye. It's a big spike in speed of the eye movement. Whereas this patient has a normal head impulse on both sides and had a massive stroke at the back of their brain there. So, I mean, I don't know how much you need to know about the following slides, really. I don't want to overload you. We said that we would run through some of the vestibular function tests we do and how to interpret the tests. What do you think, Hytham? Should we crack on through this, or should we leave it there, because the acute dizzy stuff on its own is quite a lot to take in?
If you have time, we can go through it, please, because it is the whole topic.
Yeah, great.
So,
Okay, cool. So I'm just going to run through the main vestibular function tests that we do. There are tons more that some of them are a bit outdated. Some of them are only done very rarely, like, for example, electrocochleography, which is rarely done at all. But you know, you don't need to know about that stuff. But you might at some point, you know, be told that this person's V hit was positive, but their caloric was normal. And what does that mean? And hopefully these slides will help you understand that a little bit. So the video head impulse test is just the modern version of the head impulse that we were talking about earlier. The head is turned quickly while the patient fixes gaze on a target. So they don't look at you, they look at the wall. They look at a target on the wall. You stand behind them and you move their head. It's assessing the semicircular canals, and it can assess all 6 semicircular canals. So the bedside head impulse test is really looking just at the lateral canals, but the video head impulse test could do the anterior and the posterior canals as well. It's very quick. I can do them in about 4 or 5 minutes, all 6 canals. So when you get when you get handy at them, it's really quick screener. It's like many of our tests, they are quite specific, but they're not very sensitive, meaning you can kind of trust the positive results, but you can't trust the negative results so much because they can miss stuff. So V-hit is not sensitive to smaller weaknesses, and it does improve over time. So, you know, you might see this if you see the patient within the first week of their vestibular neuritis, but by month 4, it might not look like this. It might look more like this with a scattering of saccades on it, which is another reason to to diagnose these people early on, because then you have much more concrete proof of what happened, and then we can very, very confidently send them into vestibular rehab, or or not, or send them somewhere else. But it's important to get them early, basically. So that's the V-hit. And I should say that the V-hit is a good reflection of day-to-day head movements. It's what we call high-frequency impulses. So these are quick head movements that reflect your day-to-day movement of your head, which is one of the reasons why it compensates and improves as the patient gets better, because you have to do that every day. You have to move your head around all the time. The caloric test is kind of the opposite. So the caloric test can stay positive for years, for decades, and it never really recovers. And it also does not reflect real life. This is not something that ever happens to a human being in real life, which is why you can reliably trigger off a response from the inner ear, because it's what we call an aphysiological response. So basically, they lie back, and we put warm or cool water or air into the ear, and then we generate a response just from one side, so just from the ear that we're testing. So basically, every other vestibular test that we have, almost every other vestibular test we have, tests both canals at the same time. Because if you move someone's head to the right, or you turn them in a rotatory chair to the right, their right ear, their right lateral canal will start sending excitatory neural impulses, but their left one will also be sending inhibitory neural impulses. So both labyrinths are contributing to the eye movement that you see. So in rotatory chair and video head impulse tests and many other tests, you can't separate the 2 ears. Whereas with calorics, you are separating the 2 ears, and that's why it works. So you're heating up, for example, one ear, and the heat from the water in the ear canal transfers across to the lateral semicircular canal. It creates a convection current in the canal, which starts the endolymph moving, which bends the cupula, which sends a nerve signal down the 8th nerve to the brainstem and starts the VOR off. So the VOR, the vestibular ocular reflex, then starts, and your brainstem thinks you are moving rapidly to the right side, because the right labyrinth is outputting huge signals, right? So therefore your eyes start moving to the left, because when VOR kicks in, if it thinks your head is moving to the right, your eyes move to the left, but then they flick back because obviously the eye can't turn 360 degrees in the socket, so it flicks back. So you get a drift over to the left and a flick back to the right, and that nystagmus starts small after you've irrigated and then builds up in strength and reaches the peak. We measure what it is at the peak, and then it comes down. So when you get a number from calorics, it's the average strength of the nystagmus at the height of the response. And the thing about calorics is that it's massively variable between people. So you cannot really compare the numbers you get from one patient to another. That's not the case in VHIT. VHIT is very steady. If your gain is 1, it means your eyes do exactly what your head do. If your gain is 0.5, it means your eyes do half of what your head does in VHIT. So you can compare people's VHIT numbers to each other, but you can't compare people's caloric numbers to each other, because you might do a caloric on me and I would get like 20 degrees per second in both ears, and then might do it on like Erica, on you, and you might get 50 or something like that. So everybody's different, but what should be similar is the responses you get from each ear. So in this one, you're looking for an asymmetry. It's really, really good at finding asymmetries between the two ears. And there's a certain tolerance. So we say anything up to 20% difference between the two ears is the normal range, and then over 20% is abnormal. So if your right ear produces nystagmus, which is 30% as strong as the strongest nystagmus produced by the left ear, then we would say that you have a unilateral vestibular weakness in the right ear. We might say that you have a 30% canal paresis. That's another term that's used. We might also call that I would call that quite a mild vestibular weakness. It's a mild vestibular asymmetry. If you get absolutely no response at all from the right ear and a nice healthy response from the left ear, then that's 100% canal paresis to the right, which means that you've got no function in that right lateral canal at all. So hopefully that's made a bit of sense. It's really good at looking for asymmetries. If you have a bilateral loss, for example, if you've got complete bilateral hyperfunction, the calorics will produce nothing at all. You'll warm up the patient's ear and you'll get nothing. You can cool it down, you'll get nothing. And often in complete bilateral hyperfunction, you could even do it with ice and you get nothing. So ice we use to test whether there's any function at all, because that's an extremely cold response. So you ought to get a really massive response from the ear. But in complete bilateral hyperfunction, or say, for example, if somebody's had a labyrinthectomy on one side, or they've had a chemical labyrinthectomy, then they might get absolutely no function even on ice calorics. But if you've got complete bilateral vestibular hyperfunction, there'll be no response. You could have, for example, bilateral vestibular weakness or a partial hyperfunction. Somebody's had a big course of gentamicin because they've just had endocarditis or something like that, and they are feeling much more wobbly than they were before. But you do a caloric on them, and then you won't get a positive result because there won't be an asymmetry between the two ears, because both ears have come down by the same amount. And they might not be completely gone. They might be down in the low kind of, they might be around 10 plus or minus, do you know what I mean? They might be like 8 and 8, but they'll still be similar and identical because they've both been affected by what's a systemic drug. What was I going to say? Yeah. So caloric's basically good for asymmetries. And it is our most sensitive test, and it's the oldest one we've got, and it's not nice to do to people, and it takes half an hour, and you can't do it if the patient's got lots of wax. You can't do it if the patient's got asymmetrical middle ear anatomy. So if they've had a mastoidectomy on one side, the heat transfer won't be the same in the mastoid ear. So there are some reasons why we can't do it. Also, for people who have vestibular migraine or motion sickness, they get absolutely massive responses and they feel terrible and they'll often vomit. So there's some people we avoid doing it on, right? Because it's not pleasant at all. So if you can get around it, we often try to, especially these days now we have the video head impulse test, we do this a little less. This is a new test, which is great, and it's really quick to do. And you basically vibrate the person's head at the mastoid. And if they have a nystagmus that suddenly appears and is locked to when you vibrate, so you stop vibrating, the nystagmus goes away, that is a really nice, clear sign of a vestibular asymmetry. It doesn't tell you perfectly which side, although it often does. And if it locks in with other test results, like a video head impulse test, then you can often work out which side is dysfunctional. And it doesn't improve with compensation. So like the caloric, it can be positive years down the line. We also use it occasionally for SSCD assessment as well. But this is really handy, and I'm going to start. Hey, I think I'm going to start taking this into the ENT clinic that I do with Emma, where we just rapidly go through new patients, because we already do it with the V-hit, where we can very quickly check their vestibular function. But if you add this to the V-hit, it increases the sensitivity of the battery. This we have at this center, and there are not many of them in the country, but we're lucky enough to have one at this center. And the rotatory chair test is the gold standard for bilateral vestibular weakness. And the reason for that is, like I said earlier, if you have loss on one side, so say your right ear is not completely gone, but it's really not outputting very much from the labyrinth, but your left ear is fine. When we turn you to the right, your responses, your nystagmus that is generated by the movement of the chair will be weaker, but it won't be gone, because the left side is helping it out a bit, because you're getting a bit of input from the healthy side. Whereas if you have no function at all in the inner ears, if you have complete bilateral hyperfunction, you turn a patient in the chair and their eyes do not move at all, because they can't see that they're moving. And they can't really feel that they're moving, because it's a nice smooth chair. So what you should get is a nystagmus that happens whenever you move them. But if they have complete bilateral hyperfunction, their eyes stay perfectly still, and you know that there's nothing in the lateral canals at all to move their eyes. So we do this if we suspect bilateral hyperfunction, or if we can't get a caloric on them. And we do it for kids as well. Kids like this, and they sit on their mum's knee or dad's knee, and they happily wear the goggles. This is just like we were talking about earlier. We were just talking about looking at nystagmus at the bedside, but if you want to look for vestibular nystagmus, you need to remove fixation. So this is a peripheral and central test, in that if you record the patient's eyes and this happens, this is the pattern of nystagmus, a drift and a flick. If that happens when the lights are on and they can see everything, that's a central nystagmus, because there's nothing the cerebellum can do to suppress it, because it's probably generated at the level of the brainstem or cerebellum. But if it's a vestibular nystagmus, then when the lights are on, you won't see it, because the cerebellum is stopping the eyes moving, because it's using the visual input. But when you put the goggles over and they can't see anything, this nystagmus will come out. So that tells us there's a peripheral vestibular asymmetry there. Then you might occasionally hear about saccades and smooth pursuit. So these two are the two main tests we do for central vestibular issues, because they just test the oculomotor pathways in the brainstem and the cerebellum, and often when these are deficient, there is also a central vestibular problem. So the most common reason for these to be not right is either space occupying lesion, infarction, or most commonly probably lots of small vessel disease affecting the pons. So where the vestibular nuclei are they're on the outside of the pons, and you can often get in older people slightly dodgy saccades and smooth pursuit, because they've just got really bad white matter disease in their brainstem. So this is just basically they have to watch a target moving around on the screen, and their eyes have to track it like that. And we look for particular elements of that test that tell us that they're not doing it right, and that the reason being that it's a brainstem or cerebellum issue. Same with the smooth pursuit. So this should look like a sinusoid. It should look nice and smooth, but when their eyes do this, that is what we call saccadic smooth pursuit, and those circuits are in the brainstem and cerebellum, mainly in the cerebellum, And if you see that on VNG, then it's a immediate red flag. It's a definitely, can we please scan this person and maybe send them to neurology? And also you'll see this at the bedside. If it's that bad, you'll see at the bedside when you move their eyes from side to side, you'll see that it's really saccadic. It's just choppy, 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 choppy. It's not smooth. And probably finally, I think VEMPs, which you might have heard about, which we do to test the other two bits of the labyrinth that no one ever thinks about or talks about because everyone's obsessed with semicircular canal function. And even our definition of peripheral vestibular dizziness is all about vertigo, which is a sensation of spinning. So we often say things like, you know, were you spinning? Were you spinning? And if they're not spinning, you think, oh, maybe it's not vestibular then. But there's two other organs in the vestibular system, in the peripheral vestibular system, the utricle and the saccule, and they encode for linear movement and not rotatory movement. So, you know, when somebody has middle ear surgery and they're dizzy afterwards, or if they have cochlear implant surgery and they're off balance afterwards, it's often not that the semicircular canals have been affected, but that the saccule has been affected, which is what fires off when you go up and down in a lift. That's what's firing off the saccule. So if you disturb the saccule, you'll be very off balance, but you won't be spinning. So we can look at the function of the saccule and the utricle with cervical VEMPs and ocular VEMPs. So we place electrodes various points on the head, and then for cervical VEMPs you do it on the sternocleidomastoid muscle, and for ocular VEMPs you do it just underneath the inferior, where the inferior oblique is. And it's evoked potential stuff. So basically we play a sound into the ear 100 times or something like that, and then we record tiny little potentials from the muscles, and we average them over a certain amount of time, and then we can tell us that whether that system is working or not. So we can compare both sides like calorics, because calorics and VEMPs are the only ones that test on one individual ear at a time, and we can look for asymmetries between the two sides. And then the other thing that CVEMPs are used for a lot is for detecting SSCD, superior semicircular canal dehiscence, because if there is a dehiscence at the top of the superior canal, more pressure, sound pressure, and intracranial pressure can get into the vestibular system. So you can trigger off a CVEMP with much lower intensity of sound in the dehiscent ear. So basically, we have a whole protocol for doing it, but if somebody has a dehiscence in the left ear, then they'll probably have a CVEMP threshold that's much, much lower in the left than it is in the right, which is combined with a CT of the temporal bones. That's the gold standard for diagnosing SSCD. And if you come across anyone you think has got SSCD, talk to Simon Freeman, because he's pretty good at that stuff. And then don't worry about remembering any of this at all, because we'll tell you if we can't do it, but there are reasons we can't do certain tests. These are all from our professional guidelines. The ones to watch out for is if you really want someone to have an urgent caloric, but they very recently had eye surgery or ear surgery, we're probably not going to be able to do it. Similar with very recent eye surgery for BPPV, we don't really, if we suspect BPPV and somebody's just had eye surgery, you know, just had a retinal detachment operated on, and then we make their eyes flip around, we don't really want to be responsible for disturbing that work. So so watch out for that. Also in CVEMPs, with VEMPs, I don't think even our consultants know this. It's over 60. We can't get any VEMPs on people over 60. It just doesn't really work very well. So there are certain reasons why we wouldn't be able to do these tests, but most of the time we'll give it a good go if we can, and we'll do alternative tests if we can't do the ones that are contraindicated. And I think that's it from me for today. So far.
Good.
There's a lot.
Thank you so much.
There's only 2 people on the call, I think. So any?
5.
Oh, 5. Okay. Has anyone got any questions? Don't worry if you don't. But happy to take questions.
We have loads. I will leave myself till the end. So
Okay.
any questions from the team, guys, before I try to ask David?
Lily Stain, thank you. It was very informative.
Cool, no worries.
Let me ask you, David, because this is really amazing. You have covered everything in the vestibular assessment and indications, even contraindications for things. I would say that you will have a good approach for these patients from your side because you are quite expert in that. So the indications will differ from your side if we are seeing the patients from the first instance in A&E or the ward. So and then the battery of investigations will depend on where are we suspecting the lesion actually. But let me ask you a few questions first, please, if you don't mind. So if you said about the hints, if you are doing it right and left, so if it is you're doing it on the right and the saccade was to the left, so this means that there is a right-sided stroke, right, or a VS?
There's a right-sided peripheral vestibular issue, right? So it's the direction that you push the head in. Do not worry about the direction of the saccade, okay? Because it will always be back onto your nose. It's all about the direction that you pushed the head in, because that is the labyrinth that should have fired off, right? So if you push the head to the right labyrinth should fire off. And if it fires off successfully, then the eyes will stay on your nose. And if it doesn't fire off successfully, the eyes will drift away from your nose and have to jump back onto your nose. So yes, in that situation, the saccade is to the left, but don't worry too much. The thing to concentrate on is what direction did you push the head in?
So the direction that you push in the head in is the direction that you're testing.
That you are
testing.
It's the ear that you're testing.
This to the to their right.
Yeah.
Testing the right ear.
Exactly. Yeah.
Okay, and that's the ear.
So that's the ear.
If it has that thing, that's okay. That's the right.
Yes, exactly.
So if it is still positive, we don't differentiate between vestibular neuritis and a posterior fossa stroke, right?
Yes. So if it is positive, it is highly likely that it is vestibular neuritis. Okay, it's 91% sensitive for that. Now it's not 100% sensitive, so there is a very, very small chance that the posterior fossa stroke is not in the cerebellum and is in fact in the brainstem or in the supply to the labyrinth itself, in the blood supply to the labyrinth. That is a small chance. It's, you know, doing the other elements of the hints brings up that sensitivity very, very high, like high enough that the people who designed it feel that you ought to be able to discharge without an MRI scan. But that's always up to the individual clinicians involved, right? So if you get a positive head impulse and there are no cardiovascular risk factors, there's no focal neurological signs, it's very, very likely that it's just vestibular neuritis. But
that you're answering my question about whether to offer an MRI scan or not if it is positive. But as you said, if there is neurological deficit or ataxia, for example, so we will still do an MRI scan.
Yes, absolutely. There is a slide that I may have hidden that is kind of useful in this. Where is it? Here we go. Let's add this in. I'm going to just share it. Come on. Right. Because, yeah, you're right. If you're going to be doing this, then you want to be confident. I mean, there is so much reading out there on hints. So if you're interested in it, if you start doing this more, there's tons of stuff out there. Clues to a central cause. Truncal ataxia, I already mentioned. So if the person just cannot stand up, that is a massive red flag. And also if they have a complete and sudden total loss of hearing in one ear, that's a big red flag. They definitely need a scan. The deadly Ds of central dizziness, these are the focal neurological signs that you do sometimes get with posterior fossa strokes. Diplopia, dysarthria, dysphagia, dysphonia, dysmetria, dysesthesia. I think Rosie covered all these. She covered some of them last week. Inability to stand is the truncal ataxia. What else have we got here? Acute new hearing loss as well. Okay.
Yeah. Great.
But there is the whole, the people at Hopkins have been trying for years to get an absolutely bulletproof algorithm to make sure nobody is misdiagnosed with vestibular neuritis when they're really having a stroke, and that nobody is put on a stroke pathway and over-imaged and bed blocking when they could have been sent home. They've been trying to figure out that algorithm for years, and it's really, really difficult because every patient is complex, every situation is complex. There'll be multiple people inputting into the case, so it's just a clinical judgment thing on the day. I mean, the safest thing to do would be to scan everyone, right? But you can't always do that.
Which happens, by the way. So when we are referred a patient, they already have a CT scan at least.
Yes, but the CT, I mean, the CT is so insensitive for these strokes that I wouldn't even consider that. The question is whether or not to have an MRI of the head.
Okay.
And then it's different in different hospitals due to the weight on urgent MRIs, right? So it's not. There are many factors that go into it.
Okay, the other question about vestibular suppressants, as long as we are not using it except in a very acute stage, which is 2 days, when would you recommend us as trainees to prescribe these drugs to the patients in acute setting?
Yeah, so the literature on what drugs suppress the vestibular system is not actually that brilliant, but there are certain drugs that we know put a clamp on the outputs from the labyrinth, and they are cinnarizine, which is a over-the-counter motion sickness pill, cyclizine, I think, and meclizine, which those two you don't really get that much in the UK. Prochlorperazine, as far as we know, or certainly as far as I know, does not suppress the vestibular system, but it's not. I don't know if it's 100%. And prochlorperazine, as I'm sure you know, is an antiemetic, but it's also an antipsychotic. So, and it has, if people get told by a GP, which they often do, or in an acute setting, here, get these, you need to get a prescription for these, 3 a day, and then they take 3 a day for years on end, they end up with a tremor or their extrapyramidal symptoms. So they only really need the anti-sickness when they are at risk of vomiting and not being able to keep anything down, right? So 3 days is the advice, I believe. 3 days of prochlorperazine to, keep them hydrated and get them through the worst of it. And then central compensation will kick in for the vestibular problem, and they will feel better anyway. Loads of patients will tell you, I was feeling terrible, and then my doctor gave me these pills, and they sorted me right out. And it's like, it wasn't the pills, it was the passage of time. There are no good drugs for dizziness, and beta histine is a complete waste of time. It does work for many AS patients, but we think it works as a placebo because there are big, massive RCTs that show that there's no difference between beta histine and placebo, even for many AS disease. So it's probably going to be prochlorperazine in the acute setting, and that's it.
Great. And about the vestibular rehabilitation, when you mentioned that in your plan, what does that mean? Is that a brand of exercises or something else? So which patient to refer to you as a vestibular rehab?
Yeah, cool. So Brandt-Daroff exercises are a BPPV treatment. They are a home treatment for BPPV. We actually don't really chuck them out very often because we would rather treat the BPPV ourselves, because there's a slight risk. The risk with Brandt-Daroff exercises is they either old people try and do it at home on the bed and they fall off the bed and they break their hip, or they do it wrong and it doesn't work, or they do it wrong and they send the crystals into the wrong canal. And so we generally stay away from Brandt-Daroff exercises. The other set of exercises that have the names of old white men are Cawthorne-Cooksey exercises. So you might have come across those, and you might come across some old school consultants who give out Cawthorne-Cooksey exercises. Those are extremely basic vestibular rehabilitation exercises. And they're better than nothing, but they're not nearly as good as proper vestibular rehab. So vestibular rehab is normally done by physiotherapists or audiologists, and is a long-term thing. It's going to take at least 6 months to be effective. Some people maybe slightly less, some people quite a bit more. It's home-based exercise program that they would need to do every single day. And it takes the form of things like standing in particularly challenging ways, walking in particularly challenging ways, and movement of the head. Like, I don't know if you can see my face, but you like gaze stability stuff, like getting the VOR working again, training the brain to use other inputs to move the eyes, like the cervical ocular reflex and things like that. So it's really the Cochrane review on vestibular rehab is like bulletproof. It's really good for most patients if they can do it right. And also it's much better, the sooner you can get them started on it, the better. So the wait in audiology for vestibular rehab is 6 weeks and no longer. So if you see someone on the ward and you are nice and happy that they've just had vestibular neuritis, especially if they've got a normal MRI scan, the place they need to be is vestibular rehab as soon as possible.
Okay, so this will be like a chronic vertigo patient, most probably, or after a VN attack.
Yeah, after a VN, what tends to happen after vestibular neuritis is you spin for a couple of days, and then the spinning stops when you stay still. Because you become what we call statically compensated. So it's not spinning when you're still, but when you move your head around, it still spins a bit. And then over the next couple of weeks, that gets less and less and less. But what you find is your balance is generally not that great. And when you move quickly, the world takes a few seconds to catch up because your eyes are still saccading, and you feel dizzy or you feel off balance when you move quickly. So those patients respond extremely well to vestibular rehab because it gets them moving again. It gets the brain compensated even quicker. And with good vestibular rehab in person that does it well, you can have them feeling more or less back to normal in a matter of months. But when we talk about chronic, you just said like chronic vertigo. So when we talk about chronic dizziness and vertigo, that's more measured in terms of like 6 months and longer and maybe a year. And that means chronic to me means it's just there all the time and it won't go away and it feels horrible. And when you're taking a history of a patient who says I'm dizzy all the time, you need to go back to the start. How did this start? And if it started with what sounds like vestibular neuritis, maybe they just haven't compensated for that vestibular neuritis and they've become more chronically dizzy. And they can often develop this thing called triple PD, PPPD, which stands for persistent postural perceptual dizziness, and that is almost always because they either have a background of anxiety or they had an extremely anxious response to the initial event. And one of the things that will definitely increase a person's anxiety about their vertigo is not knowing what the hell it is. Am I dying? Am I having a stroke? So if they can get reassurance early on that you're not having a stroke, you're not dying, you haven't got a tumor in your brain, you're having an inner ear inflammation, a benign inner ear inflammation, that massively cuts down the risk of triple PD.
Thank you. Regarding that, Osama is asking, is there a specific investigation to help in this diagnosis? Triple PD?
No, I wish there was. I really wish there was. No, it's a clinical diagnosis. There are signs that we pick up on our testing of triple PD, and there are also there's a definite. You just get a vibe. I just get a vibe for these patients. They often have coexisting anxiety, often migraine, often other things like chronic fatigue or fibromyalgia. But the main thing is that there's anxiety in the past or there's anxiety around the event, and it just makes everything. It causes all these reactions, these certain brain networks that react to kind of protect you while you're dizzy. They stay on high alert and they stay at this level of hyperactivity that doesn't go down, and so they just feel dizzy all the time. And triple PD patients they'll have this feeling of dizziness that literally never goes away, that is chronic, that is there all the time, with the possible exception of lying down, which is why we call it persistent postural perceptual dizziness, because when they're up and about in a particular if they're moving around, they feel that the world moves around with them, but when they lie down it goes away. And they're also very visually sensitive. They get triggered off by visual complexity or visually busy places or bright lights, things like that.
Thank you, man. 2 questions from Shalini. She's asking, what would you recommend for Meniere's and long-standing in the long run? Is it intratympanic injections, steroids, and if, how often?
Yeah, great question. So if we think someone has Meniere's at this hospital, I would want them to be seen by Emma Stapleton, Simon Lloyd, or Simon Freeman, because those are the three people who regularly do intratympanic DEX for Meniere's patients. I'm sure that there are plenty of senior registers who could also do it, and I think there is an idea that we would have a regular DEX clinic to support Simon Freeman in particular, because he has so many Meniere's patients on his books, and they need top-ups. So the thing about intratympanic DEX is that there's a kind of vaguely agreed understanding, although there's no good research to support it, but most people will do 3 injections over the course of 3 weeks. That's the standard approach that I'm aware of, but I don't think it's that evidence-based, but it does seem to work for an awful lot of people, and it has been revolutionary in treating Meniere's because it's way better than anything else. There isn't much else. There's beta histine, which is there's dietary stuff, which is do you know what I mean? It's not great. But IT Dex really does stop people's episodes. So three injections over the course of 3 weeks, and then Emma in particular will then basically say, right, as long as those episodes have stopped, then you go on to like an open appointment for her, and usually you get somewhere between 6 and 18 months of symptomatic relief, and then you can come back anytime if your episodes start again, you can come back and get another course of injections. Meniere's itself has probably got something like on average a 10-year lifespan, plus or minus a few years, so it will burn out itself in 10 years. And yes, some do recur in spite of intratympanic DEX, because it's just all it's doing is it's a steroid, right? So it's just calming everything down for a while, but it's not treating the cause of it at all, and we don't have a cure for it.
Thank you. Have you seen? So yeah, this is the question related to Meniere's before we move from it. When to shift from steroids to gentamicin injection?
Yeah, great question. If they usually, Emma and Simon will think about doing that if they didn't respond at all to the first course, or maybe if they don't respond well after a few courses. So it's a conversation to have with the patient, because obviously it wipes out the vestibular function in that side, and they will have then a significant imbalance because they've got a sudden massive vestibular asymmetry. But that's the kind of thing that we can rehab them for. We can rehab them for that. We can do vestibular rehab with them and teach their brain to compensate for having one ear down, and they can still live a completely normal life in most situations. The only risk with that is if you wipe out the vestibular function in one ear. Obviously, there is a small risk of auditory loss as well. But a probably slightly bigger risk is what about 10 years down the line if they get Meniere's in the other ear? Because I can't remember the statistics, but there are a significant proportion of people who will get it bilaterally. So if you wipe out the vestibular function in the first ear, they'll be really happy with you because their Meniere's episodes will have stopped. They'll be so happy, and then 10 years later they'll be like, what do we do now? Because you can't wipe out both.
Sorry, is your rule here in those injections is to do a caloric test to let them know which or when to inject? As I understand, the caloric test will let you, as an audiologist, let them know how weak is this side, or are we going to inject it?
The thing about the gent is that we want to be completely sure which ear is the active Meniere's ear, which is really clear and obvious in loads and loads of cases, and it's not so obvious in some. So in many cases, they will say during the episode, my right ear is full, it's screaming with tinnitus, and the hearing drops. And then you look at their audiogram and they have the low frequency loss in the on the right ear, and you're like, right, it's definitely the right ear. So we can definitely inject dexamethasone, and we can and if they want it, and if they want to progress to it, we can offer them gentamicin in that ear. If you don't quite know which ear it is, it becomes a lot more risky. So then vestibular function testing does play a role, but unfortunately there's no gold standard test for Meniere's disease, but they do tend to have a particular type of caloric problem in the Meniere's ear. The difficulty is if they've also got something on the other side that makes that difficult to interpret, it's difficult. But most people, the audiogram will be the proof normally. In Meniere's, the closest thing to a gold standard is the audiogram.
Thank you. Another question from Shalini. What would you advise for an elderly people who are having long-standing vertigo and who are not compensating? still having persistent dizziness? What would you advise of?
Yeah, well, it just depends on what is actually wrong with them, I guess. I mean, that's not a great answer, but so if somebody has persistent positional vertigo, that means that they have BPPV that is untreated, probably, and we just need to treat that. Although sometimes it can be very, very difficult to treat, especially in very frail patients that you can't move very easily. But often, you know, it's the main, overwhelmingly the main cause of dizziness in the elderly is BPPV. If you mean long-standing imbalance that they haven't compensated for, again, if we can run vestibular tests on them and prove that that imbalance has a vestibular source, then we can do vestibular rehab with them. But if it's multifactorial and or it's non-vestibular multifactorial, like, you know, it's all about the MSK stuff, or they have peripheral neuropathy, or they have, you know, there are various reasons, including, for that matter, white matter disease is actually a cause of gait problems and dizziness in the elderly. So for those patients, vestibular rehab is not really the one, and they need to go to community falls most of the time. Just so all you're doing there is you're just protecting them against falls. But
Great.
yeah, and the final part of that question is still have persistent dizziness. I mean, persistent dizziness that isn't BPPV, that is there all the time, it tends to be triple PD, persistent postural perceptual dizziness, and that I don't really see many old people with persistent postural perceptual dizziness. That is overwhelmingly like younger people, highly anxious people, you know, but not generally older people, to be honest. They don't tend to have persistent dizziness. They either have positional vertigo or their balance is totally shot for lots of possible reasons.
Great.
I think that there was a question missed as well, differentiation in indications of using CVEP and OVEP.
Yeah, so OVEMs we've just started doing, but they are useful for, well, you can refer to us for VEMs and we'll try and do both, to be honest. CVEMs have traditionally been used here and internationally for SSCD diagnosis, but you can also use OVEMs, and actually there are plenty of people out there who actually in the literature who've got good evidence to show that OVEMs are more sensitive and better for SSCD diagnosis. The other reason to differentiate the two is that one probes the saccule and one probes the utricle. So if we suspect one more than the other, without getting too complicated, there are certain ocular tilt problems that are caused by the utricle, and there are certain problems that are caused by the saccule. And the other thing is, when there's inner ear or middle ear surgery in particular, the saccule is right where the stapes footplate is. So when you're messing around there and then somebody comes out of the surgery very, very dizzy, or very, very off balance, I should say, if we want to see whether there's been damage, we're probably going to do CVEMs, because it's much more likely to be the saccule that's been damaged than it is the utricle, I would say.
Yeah, that will take me to my next question, which is, what after you know where is the defect? If it is like the V hit, or you have done the VEMS, so we know now that the defect is in one canal or in the utricle saccule. What are we going to do?
Well, first of all, again, it depends on the problem. If it's a surgical issue, then it guises. So, for example, problems with the superior canal, like a dehiscence, for example, might show on a CVEM, and they might show on the anterior canal testing on the V-hit. And then when the dehiscence surgery is done, we see the CVEM return to normal, and we see the anterior canal function sometimes return to normal. If we identify where the site of lesion is within the labyrinth, to some extent, although not massively, it does guide the vestibular rehab a little bit. So many patients have this pattern that we call anterior canal sparing, which we don't quite understand so well yet, but the anterior canals are often quite well preserved, which means that their vertical head movements are much easier to make than the lateral head movements. So that kind of guides rehab a little bit. I mean, I suppose the honest answer to your question is it doesn't always change the management. You know, it's useful to know in terms of etiology a lot of the time, but if they're going to have scans anyway, you know, it's not going to necessarily change the management. But it does help us get an idea of the severity of the problem and how well it will respond to rehab, and where it is helps guide us as well a little bit.
Maybe that's why when we were in the CIE MDT, that's why you do the V-hit for those patients to predict how will they be vertiginous after surgery, right?
Yeah, so like I said, in that MDT, we now do a program of balance screening for all adult cochlear implant patients, which for about 2/3 of them is just a V-hit, and then a third of them they qualify for full vestibular function testing because of various criteria that they meet, and it's better to do a full battery of tests with them. But we do that screen for everybody for a few reasons. One is that in some cases it can help us decide which ear to put the implant in, because there isn't a good surgical case for one ear over the other, and there isn't a good audiological case for one ear over the other. So the ears have the same hearing levels, and they've been aided for the same amount of time, and there's the same amount of auditory plasticity available on both sides. So it doesn't matter which ear it goes in for a unilateral adult patient, which is most of them. So therefore, if they've got no vestibular function in one ear, or if they've got weaker vestibular function in one ear, you want to put the implant in that ear because there is a risk of vestibular damage, and then it leaves them with one good balancing ear. You don't want to put it in the good ear if they've got a dodgy ear on the other side. The other reason we do it is because some people just need support. Some people have got this far and got to a cochlear implant assessment, and they've got horrendous vestibular function, and they've just never had any physiotherapy. They've never had any attention from vestibular rehab or from community falls, or some of these people have got horrendous migraines as well. They might need their GP to intervene on that. And then the third reason is because we have a small subset of people with cochlear implants at this centre who are suddenly going dizzy within the first year of having their cochlear implant, and we are investigating as to why. And so having that V-hit is a baseline so that we can show that it was fine before the operation, if you know what I mean.
Amazing. Thank you so much. I don't know if there are any questions left, but we covered everything.
I think it's all
Great.
Thank you so much for that.
Thank you, David, and for sure we will ask for your help in further teaching, because you are quite expert here, and this will be still a big area, but we will repeat it in another way, or just like scenario-based lecture.
Yeah, we were discussing maybe something in person as well, something that we can actually come and then he can see us and assess us doing all of these amazing tests and say, yes, you're doing it right, or no, you're doing it right.
I think definitely for the new bunch of trainees from like August, September time, we should just run these 2 talks again as they are. And we can either at those sessions or another session in future, we just get all the ENT trainees together and get everyone to do hall pikes and head impulses on each other.
That would be amazing.
Basically, because you just got to practice. You just got and I think it's fair to say, I think most ENT doctors would say that you should be, you know, they're not, I mean, compared to what you guys do in surgery, it's really not rocket science. Do you know what I mean? Like, it's really easy compared to surgery, and you ought to be able to do it, and I'm sure you can do it. It's just like practice and confidence.
Yeah, we can have that as a third session after these 2 first ones, then consolidate everything in a practical. That's a really good idea. Thank you so much. We'll be in touch.
All right, no problem. Been a pleasure.
Thank you, man. I appreciate it.